Okay, dear colleagues and friends, let's continue our sessions. So we have now several sessions in a row with different topics, and we start with a session titled In the Doctor's Shoes. It's about the case discussions. And the situation is very clear. Every day in all the countries, sarcoma patients are meeting doctors, meeting experts, and the doctors are sitting in front of the patient, getting all the information from the patients, and then they need to analyze this information and then maybe start an investigation process, an internal investigation process, bring maybe the tumor board together, but at the end of the session or maybe at the end of the day, they need to give a recommendation to the patient, and the patient expects a qualified recommendation. And this session now is about that my colleague Peter will discuss with you some cases, and we put you a little bit into the shoes of the experts, so you are part of such a tumor board, and so you can discuss some of these cases with Peter. So it's my great pleasure to introduce Peter Reichardt, and many of you met him yesterday during the awards ceremony. Peter is, and we just mentioned to Robert that he's a god of sarcomas and GIST, and Peter is another god of sarcomas and GIST, well known in Germany but also globally, and he has done a lot of research during the last 2-3 decades, but also he has treated thousands of patients with GIST or sarcomas. And so it's a great pleasure, Peter, to welcome you. Thank you very much for coming to Stockholm and really bringing your time to the community.
Marco, thank you very much. Welcome everybody. So now I need 2 or 3 volunteers out of you, because as the title indicates, it's in the doctor's shoes. So you will take over the role that normally is taken over by a doctor. So you have 2 choices. Either 2 or 3 volunteers stand up, come to the front, take a seat here, because you will be the tumor board. If there are no volunteers, I will assign volunteers. So I give you a minute. I hope to see 2 or 3 in the front row, because again, you will be the experts in the tumor board we will be doing.
Oui.
So please come forward, 2 or 3. The longer we wait, the less lunch break. Very easy. We have the first volunteer. Okay, second and third. So I don't want a real expert as volunteers, so I don't see Robin any longer, so he might smuggle in and act as a volunteer. Okay, great. So, can you very briefly introduce yourself, where you come from, what's your what you do for a living or whatever?
Whatever, yes. Thank you. I'm Joost Groen. I'm from the patient platform Sarcomas from the Netherlands. I'm a GIST patient, and I have an engineering background, but actually I'm a full-time patient advocate.
Okay.
I'm Andy French from Sarcoma UK, Policy and Public Affairs Manager. I don't have a background as a healthcare professional. My experience has been working in government, parliament, charity sector.
Okay.
Yeah, hello all. My name is Sandeep Kumar. I am Ewing sarcoma survivor myself, and also I am the founder and CEO of the Digi Swasthi Foundation from India.
Okay, great.
Yeah, thank you.
All right, so you keep the microphone. We'll start with theoretical cases. I don't want to show any pictures. So the first case is a person, gender is not relevant here, let's say around 30 years old. This person goes to his or her, I will say his, but you can imagine whatever gender you like. Go see the family doctor, saying, well, there is a swelling in the upper thigh, which has been there for patient cannot remember correctly, well, probably a couple of weeks, maybe even a few months. Was painless in the beginning, but now starts to cause a little pain. Also, the function is slightly impaired, so the patient starts to worry. Is going to see the family doctor. The family doctor is a good doctor, may have listened to my lectures at medical school, and thinks, well, I don't know what that is, but it could be something dangerous. I don't know. Brief interruption. This family doctor does not have to know what this is, but this family doctor has to recognize that is something I do not really know, I do not have to know, but I have to recognize that is something where I need to send the patient to somebody who does know. That's the part of the family doctor. So it's not our goal to treat all the family doctors about rare subtypes of sarcoma, but they need to be aware that there are these things, sarcomas, and that they don't need to know about it, but they need to recognize when they need to send them somewhere. Okay. So this family doctor does everything right, says, well, I don't know what you have, but could be something difficult, I have to send you to an expert. So he makes an appointment and sends the patient to the expert. You are the 3 experts. So the patient is now sitting in front of you. We start in this order. So you see the patient. The patient comes, says, well, you ask, what can I do for you? And the patient says, well, I've seen my family doctor and he told me that this I have here in my thigh could be something difficult. He doesn't know what it is, but he said, I need to get it checked by an expert, so I came here to see you. So how do you start the conversation with the patient?
So how long you are having pain in the a particular area?
Okay.
And,
yeah, that's great.
and
We
do
already
you have
mentioned, I said the patient tells couple of weeks, maybe months, cannot really remember correctly,
Yeah,
which is normal. I mean, which patient would cross a mark in the calendar, first day of pain, and 3 months later says, well, the first pain was on 17th of whatever. So it's difficult to get a clear information when it really started. Some patients say, well, could be already a year. What is more typical is actually yesterday, which is never true, of course. But patients don't want to hear complaints, why do you come today if you have had this for 3 months? So they tend to shorten the history and say, well, very recently, maybe last week or so. So I made a very early appointment with you. Again, which is normally never true. So correct, that's what you first do. We get the explanation.
do you have any scan like X-ray or any report? And also, did you fallen down anywhere, or how it like started the pain?
So you want to see an image.
Yep.
Well, why do you ask the patient for the image? Do you think the patient comes with the image? The patient was seen by his family doctor. Family doctor says, I don't know what you have, sent you to the expert. You are the expert.
So I'll write the prescription to get like a scan done.
Okay, so based on what you just heard, you think you need a scan.
Yep.
Okay, what do you think?
I want to know how you're feeling and how is it affecting you.
Okay.
What kind of symptoms? Is it stopping you working?
Yeah, that's great.
Looking after your kids? Whatever.
Patient explains everything, how he feels, pain, everything like that. So you see, okay, that's really suspicious. And how do you want to continue?
I don't know because I'm not a doctor.
Okay.
And any other complaints? Maybe abdominal pain or whatever? Other things?
Nothing.
Okay.
Young patient is doing a lot of sports, not in the last couple weeks because a little bit of pain. So stopped going bicycling and whatever. but otherwise completely healthy. Sitting in front of you, young guy around 30, doesn't look like anything dangerous.
Go through the protocol of what are different types of tumor there might be, and what might be the most common one, most highest probability, and see where you should refer them, or you can treat them yourselves.
So let's include everybody. What we have heard: young person, otherwise healthy, has a swelling, some pain, impaired function in a thigh. What is the differential diagnosis? What do you think could this be? That's the next. But first of all, based on what thinking? Why do you want an MRI? That's all right, but you mentioned tumor. Okay, so you think it could be a tumor, right? Okay, you do clinical inspection. What do many doctors think in such a situation? Lipoma is one explanation. Exactly. I just mentioned young guy, sporty, bicycle. So people tend to say, okay, that could be a hematoma or a muscle rupture or whatever. That's what normally happens. Of course, you are thinking about a sarcoma because we are in a sarcoma session. But we have to be very clear that that's not what everybody would think in the first hand. So we have a suspicion here, and what I want to point out is that among all these differential diagnoses, the idea has to pop up, it could be a sarcoma. Not it's likely a sarcoma, but it could be a sarcoma. And what's the only way to rule out that it could be a sarcoma? We do need imaging. Which type of imaging? The doctor has his ultrasound machine, likes to do an ultrasound because he can ask money for that. Is that helpful? Well, a little bit, but not really. So you suggested an imaging, you suggested an MRI, which is correct. MRI is the method of choice. If you think it could be a sarcoma, and again, the could be is sufficient to order an MRI. You don't order an MRI if you say it is a sarcoma, but if you think it could be a sarcoma, you order an MRI. Okay, so you write the prescription, I need an MRI. What do you tell the patient? The patient asks, MRI, what is that? Is that dangerous? Why do you order this? What do you think? What do you tell the patient?
So MRI is a simple process to get a scan of the entire body and also the specific like area of the painful area to get the information that is it like any injury or any like muscles or bone issues.
Is it dangerous?
No,
is it painful?
No, it's not painful. It's not dangerous. You will simply laying on a bed, and it will be noisily a lot. Like when you enter in the machine, but it's safe and secure.
And why do I need to do this? Why do you order that?
To get the exact information about like your issues.
And what do you think this is? Is this something dangerous? Do I have to be worried?
I think it can be like a type of a sarcoma, maybe. But
what is that? What is a sarcoma? Never heard before.
So a sarcoma, a type of a bone cancer.
Cancer? You think that could be cancer?
Maybe, but
okay.
to get the exact information, we need to go for MRI.
Okay.
Yep.
Who would mention, no, let's say, who would use the word cancer in this first consultation with the patient?
Never.
Oh. Okay. Nevertheless, the patient needs to know why we do such a expensive technique. You need to make an assignment, it takes some time, so you need to explain why you do this. Telling, well, you have probably cancer is not the best thing to do. Sorry, don't want to offend. So what would be a better way to balance between and not to worry the patient? I mean, it may end up as a sarcoma, so it's still time to address these things, but in the first contact, the patient just came here, it's 3 minutes ago, and you say, oh, I think you have cancer. I don't think any of you wants this in the first consultation. Yes,
what happened to me, if I may, Peter?
Oh, yes, sure.
Is that I was told we have to exclude that it might be something dangerous.
That's a good way. Yeah? In two ways. First, it could be something dangerous. That is true. I mean, the patient needs to know that it could be something dangerous. And it's always better to do it this way around, to say, well, I want to be sure that it's not dangerous, because that allows thinking, hopefully it's not something dangerous. But we don't know yet. Yeah? So that's a good way to go. We have to rule out that is something dangerous. The patient will say, yeah, that's right, we have to rule out this. Okay? Comment?
I just wanted to answer to your question. So we should have a soft approach to the patient, not too scared. And we can say it might be something there, and it's needed this check to be sure if it is anything there, and then we will see what is it, and hopefully there is nothing serious.
Okay, good. So we all agree on this step. We need to mention it could be something, because if we say that's clearly nothing, then that doesn't make sense to go forward with examinations. So we need to mention there could be something, but it's better to put it the other way around. Well, we need to rule out that it's something dangerous. So, okay. So having said that, the patient gets the prescription, has understood why. Appointment, goes to the radiologist, undergoes the MRI scan. What do the radiologists unfortunately do sometimes? Yeah, the patient is in the machine, gets out, wants to leave. Unfortunately, some radiologists do what? Well, not a real report, but they say, goodbye, it's really a cancer. See you. These things happen. Yeah? So sometimes the problem is the patient comes back to see the doctor who ordered the MRI, has not yet seen the report, because normally we don't have a single patient, but we have many patients. So the patients come into clinics one after the other. So when a new patient comes in, I open what I already have from the patient and I read the report. Some patients think I have only one patient, so I follow up, and as soon as the report is in, I read just this report. However, I've seen 20 other patients and read their reports. So the patient is scheduled for 10 o'clock, so I open the chart, and now I read the report. Unfortunately, some of the patients have already got the report, or part of it. Something like, okay, it's real cancer, something like that. That's very unfortunate, because you need to explain what's there. So patient comes, hopefully does not yet know the result, and then you start explaining what has been the finding, because with the finding, the patient needs to learn what will be done now. So if the patient gets the MRI 3 days ago, has some information, and has the date with the doctor 3 days later, that's 3 very terrible days. Can imagine. The patient tries to call the doctor, I will see you in 2 days, but I have a question, I've just read the report. That's a very bad thing. So that should not happen. Okay, let's hope everything went right. the radiologist says, well, we need to analyze this carefully, and the doctor will explain to you when you see him next time what we found. I hope the best for you. Bye-bye. Something like that. So next appointment, you have the report. We have done a little bit of blood test. Any specific blood test for a suspicion of sarcoma? Is there the blood test for sarcoma, rule out or rule in? What would you do? The sarcoma test? No sarcoma test? Nothing? Lab completely normal, roots out the sarcoma? No. Anything?
Question before, do you know that the MRI will make with contrast or not? And I haven't without, but I don't know that's not right. And he can't see at the picture what it is.
Yeah. Well, Karin, you're right. I didn't want to go into that detail with MRI, with or without contrast and things like that. You're right, of course, that the radiologist needs to explain that to do it right, you need to give contrast and so on. But that's too specific for the discussion now. So we agree, no specific blood test. So in this otherwise healthy young patient, blood test comes up completely normal, nothing there. But that doesn't rule out anything with respect to our suspicion. Okay, so you have the findings, you have the blood tests, you have the MRI report. In the MRI report is something like there is a 13 centimeter lesion with irregular contrast uptake, a lot of contrast in some parts, a little less in other parts, and the radiologist says it's a clear suspicion of a sarcoma. That's what you read. And now you explain the patient what was the finding and what you suggest to do now.
And that would depend, obviously, but I think you would have to bring the bad news that it is a sarcoma, which is a rare form of cancer. And we don't know exactly what type it is yet, so there will be more tests being done, and the treatment will be dependent on what comes out of those the extra tests.
Good. So now is the time to bring up the suspicion that it's likely, it's not proven yet, but it's likely a sarcoma, and the patient will ask you, what is it? Can it be cured? What needs to be done, and so on. So now you have to give a little bit of explanation what a sarcoma is, that it's a malignant disease, that it can be local, that it can unfortunately spread, that there are many different subtypes, and the treatment options are various. Could be surgery, radiation, could be even chemotherapy, but that depends on some additional examinations we need to do, so the patient gets a picture what it could be and what needs to be done. Okay. So what is the next step?
Next step for the FNAC and biopsy for the particular.
That is true, but what I wanted to hear is the next step is the first presentation of this patient in the sarcoma board.
Right.
Yeah? Sarcoma board. The rule is clinical suspicion, examination, imaging, sarcoma board. In this order. In the sarcoma board, we will sit together. That's the radiologist, the pathologist, the surgeon, the medical oncologist, and the radiation oncologist, plus other people. We sit together, we look at the image, we say, yeah, that really looks like a sarcoma. And you already mentioned biopsy. So in the context of biopsy, what needs to be done now? We need a biopsy. We need histological proof. So who sticks a needle where in?
Surgeon.
The surgeon? Not necessarily. Why do you suggest the surgeon? Yes. Why do you suggest these two? Good. Yes, but why should it be the surgeon or the radiologist? It's always great if somebody does it who knows what she or he is doing, yes, but what's the reason?
Because
It's such-
right angle need to be like, yeah.
Need to have surgeon involved in the decision making because if it is we want to have the neurotype set along with the surgery.
Yeah. Somebody want?
Oh, I was just going to say, based on one of the sessions yesterday, it sounded it was important to have the surgeon that would be doing the resection later to have a really good understanding of where the biopsy was.
Exactly. So radiologist and surgeon should be involved due to two reasons. First, I already mentioned that the radiologist describes the tumor as a little irregular, more contrast uptake, areas with less contrast uptake. So we need to decide in the tumor board where should the biopsy be taken. 13 centimeter tumor, you could stick a needle in anywhere and the result could be whatever, not necessarily what you expect to find. It might be better or worse. So we need to decide where to get the biopsy. And we identify the area and say, well, this area is probably the most problematic. And if you think about a tumor that has more aggressive and less aggressive parts, you need to stick the needle in the most aggressive part. Because if the tumor is partly well and partly less well differentiated, you need to know the worst part. So we need to decide where is the place to put the needle in. That's why we sit together, look at the image and say, well, this upper part here, that's the most suspicious. There we need to get a biopsy first. Second, why you suggested a surgeon on personal experience, that's great. Unfortunately, not always the case. In worst case, somebody is sticking a needle in or taking a biopsy without brains. And what could be the worst outcome of such a procedure?
Spread.
You can maybe find nothing,
It spread.
or yeah, that's not so likely, but if you, I mean,
It can be spread to another like
yeah, that is
body part.
that is not the biggest problem here.
Okay.
But you might miss the tumor, and what does the surgeon later on needs to do?
Yeah.
Exactly. So if the tumor is in the front and the biopsy was taken from the back, what is the maximum worst possible outcome of such a wrong procedure? Yeah, everything, but for the patient immediately.
And that wrong diagnosis.
The worst possible outcome is that this patient will lose his leg because an extremity conserving procedure will not be possible anymore. Because, as we just heard, the surgeon needs out to take the tumor, the biopsy channel, and whatever else procedure was done in one part. So you cannot take out the tumor from the front, take out the biopsy channel from the back. It has to be in one. And in such a worst case, we see this once or twice a year, you need to take up the leg. That is the worst outcome based on the wrong place to do the biopsy. That's why the surgeon does not have to do biopsy himself, but the surgeon must advise, my surgical procedure will be exactly this. That's the way I will be cutting. And the biopsy needs to be done within the future scar of the surgery. If the biopsy is done here and the future scar is here, you have a problem. That's why the surgeon must be involved and must say, well, here I do the typical so-and-so. That will be my approach, direct way to the tumor. So that's where you need to stick the needle in, and that's the part of the tumor we want to get the biopsy from. And that's why this decision is done in the tumor board. That's what we call the pre-therapeutic tumor board. There are always several tumor boards. It's the pre-therapeutic tumor board, and later on it's the post-therapeutic tumor board if we come up with results. So again, clinical suspicion, imaging, board, in this order. In the board, we get the information, the interpretation from the radiologist. You get the information from the surgeon, and here we decide where exactly the biopsy will be done, from which direction and which part of the tumor we want to get the biopsy from. That's very important. Yes? Next step. We'll come to this in a second. So we have decided everything. The patient is scheduled for a biopsy. I don't want to spend a lot of time whether it's a fine needle is not allowed, a core needle biopsy or an incisional biopsy. There are pros and cons that, well, we don't want to spend time here. So we order a biopsy. We tell the patient that what we already did, there is suspicion and so on, that we need a confirmation, we need to do a biopsy. So we plan the biopsy is done, we schedule the patient as soon as we have the result of the biopsy. And now the result of the biopsy comes up, and it's an undifferentiated pleomorphic sarcoma, a UPS grade 3. Okay, so what is the next step? You already suggested, so you get the voice. What do you next? Whole body, who thinks a whole body MRI would be justified here? I think in most countries it would not even be paid for. We know it's a UPS grade 3. So if there would be metastases, where would you suspect them? Exactly. Anywhere else? Let's assume the lung is clear, nothing there. Liver? Very rarely. Lymph nodes? Nearly never. Below 1% in UPS. Maybe 1%. But you ask for specific pain. The patient's completely no symptoms at all, no bone pain, nothing. So clearly no indication for a bone scan. No total body MRI. Very clearly, if this patient has already metastases, they will be in the lungs. If there are many in the lungs, then there might be some elsewhere, but as obviously no rule without exceptions, but very clearly if then, so if there are metastases, they would be in the lung, and if in the lung there is nothing, it's extremely unlikely that there will be somewhere. But this applies to the UPS in the thigh. It's different if we talk about a uterine lyo. Yeah? So sarcoma is 1 out of 100 family members. So in the UPS, lung, so we do a thoracic CT scan. No MRI. MRI of the lung doesn't work. It's a CT scan. Contrast? Karin, contrast for a thoracic CT? Hopefully not. We don't need a contrast enhanced CT for a diagnosis or exclusion of lung metastases. No. The lung metastases show up without contrast. You use contrast if you have to look for lymph nodes and mediastinal lesions. So in the context of a lung cancer, it's always contrast. But for detection of lung metastases in a sarcoma, no contrast. It's a plain CT scan without contrast in this situation. Huh?
Just
Okay.
Peter, a brief question. Could you just explain maybe the step between the biopsy and, because there's always the pathologist involved, and if you involve the pathologist, what does this mean for the patient? How long has he to wait or she to wait for the results?
Too
Is this
long.
done? Yeah, that's a good. Is it done in one day
Yeah,
or maybe?
yeah.
Yeah.
Yeah, good. Not question, but
Yeah.
suggestion. Well, it depends what sarcoma it finally is and who the pathologist is. So it will take a couple of days. This you need to tell the patient. So the patient will not call you in the evening when the biopsy was done in the morning. You have to tell him it can take a couple of days, maybe even longer. It depends how difficult the diagnosis is. That can take some time. Please be patient. Don't call me in an hour. I will not have the result. Very important, the diagnosis has to be made or confirmed by an expert pathologist. And there are not so many around, which makes things a little bit more complicated. So you might get the diagnosis that is likely this or that type of sarcoma, but there are very difficult subtype specific diagnoses that may take additional time. And every now and then we have to wait even a couple of weeks until we have the final confirmation which exact subtype of sarcoma we are dealing with, depending on who got the specimen in the first hand. So let's assume it's done in an expert site, so there will be an expert pathologist available, and then the diagnosis will be made in, let's say, a couple of days, and comes up, as I already mentioned, as a UPS grade 3, which is a not so difficult diagnosis because you can make this very clear as an expert pathologist without very complex molecular subtyping. But there are other examples where the pathologist will say, well, that is this or that, but I have to do additional molecular analysis. Please give me another 2 weeks. That's not uncommon, but in our example now, that's not the case. So 4, 5, 6 days later, we get this diagnosis, UPS grade 3. Good. Okay. So we have the confirmation, histology. We have the staging procedures, which again consist of mandatory CT scan of the lungs, plus X, depending on the subtype, depending on complaints. Some subtypes might involve lymph nodes, like a synovial sarcoma. UPS, basically never. And also metastatic sites depend on the subtype. UPS, mainly lung, if there are any metastases. So that's the staging procedure. It depends on the localization of the tumor, on the subtype of the sarcoma, and of, subtype and the anatomical localization. So we have confirmation. Fortunately, there are no metastases seen in the lung. And now comes the difficult part. The patient asks you, what is next? What do you suggest to do? UPS, 13 centimeters, G3, no lung metastases. What's the possibilities? You want to make any suggestion, or
UPS is not my field of expertise, but I would suggest that it has to be decided in the tumor board what will be the options, and they will be laid out to the patient what will be the different options, if there are different ones with all advantages and disadvantages, and then together you decide.
Correct. That's the second time the patient will appear in the sarcoma board. Now everything is on the table. The histological diagnosis, the staging, everything. Now we make the treatment decision. So what are the options? So let's first of all just summarize what are the options before we prioritize this over that. We could do surgery now. That is an operable tumor based on absence of metastases. 13 centimeters in the upper thigh, it's operable. One option. Other options? Immunotherapy. Okay. Outside a clinical trial, basically never ever. Surgery. Anything else? Observation. In a G3 UPS 13 centimeters. Okay. What do you want to observe? The date of death?
Neoadjuvant therapy?
Neoadjuvant therapy, which could consist of chemotherapy
or radiation.
Or radiation. Okay. Anything else? Surgery first, chemo first, followed by surgery. Radiation first, followed by surgery. Anything else? Targeted therapy in a UPS G3, none that I would be aware of. No options. Anything else the patient could be offered? Participation in a clinical trial, always a good thing to suggest.
Lymph perfusion?
Lymph perfusion is an option. Anything else? Ever heard of hypothermia? What ablation? In a 13 centimeter tumor, technically completely impossible. So hypothermia as a combo element to chemotherapy or radiation therapy is another option. There is a prospective randomized phase 3 study suggesting that the addition of hypothermia improves overall survival by roughly 10%. So that's something that needs to be told the patient. Most sites do not offer this, but if you don't offer it, that doesn't mean that you don't have to offer it to the patient. You have to offer the patient all the options, and if one of the options is outside your institution, it's the patient's decision to change the institution if he wants to get this other specific therapy or not. It's the patient's decision. It's not your decision. Something like, we don't do hypothermia, so I don't offer this to you. That's not correct. You can tell the patient, we don't do it. There are some advantages, but you need to travel 300 miles to come to a site who does offer it. Is that something for you? Then I can make a contact and ask my colleagues over there whether they want to talk to you and explain what this is about. And the patient says, yes, I want to take any chance. If this could be helpful, please send me there. Or the patient can say, well, no, that's too bothersome, 300 miles. I don't want to do that. Then you take a note You explained the patient the possible advantages of an additional hypothermia. The patient thought about it and decided not to take this offer.
Maybe just a question, because I'm not sure whether everyone in the room knows what hypothermia is. And you know that there is hypothermia and hypothermia, as we all know. I think this must be an important...
Very briefly, we are talking about regional hypothermia, not whole body hypothermia. Regional hypothermia means that you increase the temperature in the area where the tumor is by basically microwave energy. The area is heated up to 41.5 degrees Celsius. And the background is that chemotherapy, some chemotherapy, and radiation works better at this temperature compared to the regular 37 degrees. That has been well proven. Yeah? And the chemotherapy works better, or the radiation therapy works better in the area where you apply your extra temperature. And that's just the tumor area, not the whole body. It doesn't make sense to heat up the leg if the tumor is in the arm or otherwise round. Yeah? You want to heat up the area of the tumor because the chemotherapy will work better, up to 5 times better, in the area with a higher temperature. That's the background. It's for most sarcomas. The study that was done was not subtype specific, but high-grade soft tissue sarcoma.
Is it because it's a catalyst?
There are a little bit complicated mechanisms behind, which I don't want to spend too much time on, but let's keep it simple. The chemotherapy works better, kills more cells at this temperature level compared to the normal temperature level. And it doesn't cause, actually, I wouldn't say no, but no real side effects. You just heat the thigh in this case. So that's an option. So the options are primary surgery, pre-op chemo plus or minus hypothermia, pre-op radiation plus or minus hypothermia. Lymph perfusion is theoretically an option, but the clear indication for lymph perfusion is avoiding an amputation, and the surgeon tells you no problem. Technically, I can take the tumor out. No problem. So this is clearly not an indication for lymph perfusion. If the surgeon would tell you, no way, only way to take this tumor out, not in our example, but generally, this would need an amputation, then you need to go for lymph perfusion. If you don't lymph perfusion, if you don't offer it yourself, what do? Cut the leg or send the patient otherwhere? Cut the leg. That's what most people do. Yeah. They rather cut the leg instead of sending the patient 300 miles to the east, west, north, south, because better doing yourself than sending the patient otherwise. That's the unfortunate reality. Karin, huh? Whatever the reason is. It's not only money, it's that you don't want to tell the patient that others can do better than you can do in this case. Okay, well, the difficult part now is we get 5 more minutes.
Yeah, 5 minutes.
We started 15 minutes late.
Yeah.
It's not my fault.
No, I know.
Funny guy.
Always.
Always. Difficult. Now comes the most difficult part. You told your patient that's the options. And the patient says, well, doctor, what are the advantages and disadvantages of these suggestions? Do I have to make the decision? I cannot say what is best for me. You need to explain. So what would you think is the time frame for the upcoming conversation? Denise, we talked about this yesterday. Is that a 15-minute issue? Yeah, we were chatting over lunch that the scheduled time frames are quite often in the 10 to 15-minute range, and we completely agreed that there are difficult discussions you can never handle in 15 minutes, and this would be one. So we need to, I would plan an hour for such a discussion. And I would invite the patient to bring relatives, whatever that means, wife, husband, parents, children, depending on the situation, because it's better to explain it to a broader group, because then they can discuss afterwards. Did you understand what the doctor was meaning when he said this or that? Or they want to share the decision making, which is important, because we do see the situation that if things go bad in the further course, then people start arguing. I told you you should have done that. You didn't want to do it. I told you, go for chemo. You rejected. Something like that. That's why I say, okay, whatever, make the decision together, and you have to accept whatever the fate will be later on together. So if you decide we don't do this or we want to do this, then you made the decision together, and if it works, fine, but if it doesn't work, then you say, well, it was our common decision, now we have to accept and we have to go through it together. Very strong recommendation to do it like that. And that's what you should recommend the patients you are advising. Bring your relatives, whoever that is. It could also be a friend, so it's not relative, but whoever may accompany the patient. I normally don't accept groups beyond 10, joking, but that happens sometimes. So I tell them, well, please, maximum 3 or 4. Mostly it's just 2 or 3. So you have to be clear here. And then you explain all the possibilities, and you have to explain what are the pros, what are the cons. And in the end, this will be what we call, and you know how we call it informed consent. That's very easy to translate. Informed consent means that everybody in the room is informed about what are the advantages and disadvantages, and then the patient consents to the decision. If you tell the patient, I'll take the tumor out tomorrow, please sign here. That's a consent, the signature, but it's not an informed consent. Informed consent means you offer all the options, explain what's the pros and cons, take your time, think about it, tell me your decision tomorrow, next week, whatever. Is this an immediate emergency? Do you need to act within hours? Clearly, no. So never accept, I need your decision in half an hour, because we need to finalize tomorrow's operation plan, so I need to know yes or no. Unacceptable. Unacceptable. This decision needs time, and it's never an emergency. Clearly not. If the patient says, I need to discuss this, I have to think about it, I inform you early next week, completely okay. Definitely. I normally tell my patients, take your time. If there are further questions, that's okay. Take your time, make your decision, share your thinking within the family, whatever that means, and then make the decision. And that's the informed consent. No? And once you have made your decision, you start the procedures, whatever they are. And since Marcus has just cut my time, we have to stop at this, that there are these options we need to discuss with the patient. We would take an hour to explain everything. What are the advantages of pre-op chemo? What are the advantages of supplementary hyperthermia? What are the advantages of pre-op radiation therapy? What would be the option of primary surgery, would we then consider chemotherapy afterwards? If we consider chemotherapy anyway, why not do it firsthand? And all these things. So this we need to discuss. The patient needs time to think, and it ends with informed consent. I stress this word several times now, informed consent. Why do I do this? Because unfortunately it's not standard of care, informed consent. Mostly it's consent. We could even call it very badly pressed consent or something. I need your decision now. And the patient says, oh, obviously an emergency. Well, okay, I sign here, yes, surgery. And then surgery is done. 2 weeks later, then the patient calls Karin or any of you. In Germany, mostly Karin, and say, well, I had surgery 2 weeks ago for a sarcoma, UPS, G3. Surgeon told me everything went fine. And then Karin says, what do you say normally in such a case? Yeah. And then the patient comes, gets the second opinion from me, and the first thing I ask this patient, are you prepared to learn from me that I disagree with what was done? And sometimes the patients are very disappointed because what they hope is that I confirm, great, well done, everything okay. But in many cases, roughly half and half, I have to tell them, I would have done something else. And I told you yesterday, I asked the patients before whether they are prepared to learn that what was done was, from my expertise, far from optimal. And that's not easy for many patients because they think whatever doctor they have seen, they will get the best advice. So if the surgeon told them we need to do surgery tomorrow, that was obviously the best thing to do. And I'll tell the patient, well, listen, I would have done it completely different, and that are the reasons. And if you want to get a second opinion, please get it before a decision. And that's what I tell all the patients. If you want to come back and get my advice in the further course in the upcoming years, please come before you made a decision. I don't want to see you after a decision made. That doesn't make sense. So patient develops lung metastases, they are taken out, and the patient come and ask me, was that okay? And I said, no, that was bullshit. You should have asked me before. If you always come after a procedure, you can leave it. That doesn't make any sense. If you want a second opinion, get it before something happens. And in this situation, if the patient asks Karin, they told me to G3, UPS, they want to do surgery next week. Then you can give an advice. If they tell you it happened 2 weeks ago, you can only say, well, you can still get an advice what should be done now, because of course we can offer things even after surgery, but the best is to ask before something happens. Then you can advise what's the best. The patient can still decide. I stick with the initial decision. I believe my surgeon was right. He wants to do surgery. I still go for primary surgery. Okay, yes, decision of the patient, no problem. I take a note. I took 1 hour to explain everything. Patient still wants to go back to undergo surgery in this small hospital where they haven't done it for 5 years. Therefore, the surgeon is very keen doing it. Oh, I haven't done this for 5 years. Great. Funny. I've done it in my younger years, but now, since 5 years, I have not done it. That's very, very interesting. I'm glad to do this again. Okay. If the patient has got all explanations and still makes the decision, not my problem, sorry. Yeah? But you have to make sure that the patient has understood what the risks and the possible benefits are. And if the patient makes a decision, then it's his or her decision. Important is you take a note. I took 1 hour. I explained everything. The patient decided to do this, closure of the chart. Then it goes the way. And many of these patients come back later on, doctor, you were right. I should have heard to your advice. But then it may be too late in the worst case. It may be still time to do something, but in some cases you have to say, sorry, that was far from optimal. Of course. One more minute.
Yeah.
I tell the patient that this is a rare disease, but there is a very active patient organization in Germany, the German Sarcoma Foundation, that if they want to, and I clearly tell you, even if you are all advocates, not all patients want it. Some say, no, I don't want to meet in private with other patients. I want to get through this and then that's it. Okay, your decision. But I tell them, well, there is a very nice website. You can check. There is a lot of reading. You can watch a couple of YouTube videos. You can inform yourself. There are a couple of telephone numbers which all end up on Karin's handy and finally on mine. And then you can inform yourself. And take your time. It's not an emergency. Take your time, and if you need 2 or 3 days, that's okay. Nothing will happen within these 2 or 3 days. And then you make a decision, but take your time. Yeah? So, yes, I do that. Yeah, most of the doctors don't do a lot of things. We just conclude it should be done. Yeah. But that's the problem.
So, thank you very much. Thank you very much, Peter, for this great talk. Always with a lot of expertise, but also with a sense of humor. Thank you very much for this. So, thank you.
Thank you. Next year, I know where will be SPAGN next year?
We don't know in the moment.
We don't know yet. So, if you want, tell those organizing the program that you want the second hour next year.